Thank you so much. That was very, very informative and inspiring. Without much ado, let's move on to the next session. Very appropriately, the postprandial session is dedicated to the gut, the GI system, which is highly ignored. It's my honor and privilege to be calling upon the chief moderator for this session, one of my mentors, Dr. Sunil Karanth, from HOD and Consultant Critical Care, Manipal Hospital's Old Airport Road. The chairpersons for this session would be Dr. Ranveer Tyagi, Head of Critical Care Department, Synergy, Agra, Dr. Asif Iqbal, Apollo Hospitals, Kolkata, and Dr. Aruna Ramesh, Professor in HOD Emergency Medicine in Ramaya Medical College. I welcome all the chairpersons and the moderator. Next, I call upon Dr. Kshitija Kulkarni, Regional Head Medical Services, Manipal Hospital, Dr. Karthik Rao, Senior Consultant Critical Care, Intensive Care Unit, Yashwantpur, Manipal Hospitals, and Dr. Chandrasekhar Taluru. Welcome, sir.
So, good afternoon, everyone. I hope all of you can stay awake and in this session. This will be a topic on gastrointestinal system, which is the ignored system. And of course, today we know that gastrointestinal system is the crux of a lot of good and bad things that happen when we talk about organ crosstalk. So without wasting much time, I would like to invite Dr. Jojo John for his topic, which is fluid management in acute pancreatitis. Does the severity matter? A lot of water has flown under the bridge, and I'm sure Dr. Jojo will let us know how do we deal with the resuscitation part in pancreatitis. Thank you.
Thank you, Chairman, and thank you, organizers of JICS. The short answer to the question is yes, but as always, the devil is in the details. We all know that fluid resuscitation is the cornerstone of critical care management of acute pancreatitis for the very clear reasons that we all know. We all are aware of the intense capillary leakage that occurs after pancreatitis, producing a third spacing and volume loss, and the reduced enteral intake, vomiting, tachypnea, diaphoresis, all leads to an actual volume depletion. And there is evidence that the reduced perfusion that this produces in the inflamed pancreas directly aggravates the inflammation and necrosis of the pancreas, as well as the fact that a correction of the perfusion of the pancreas might actually protect it against a further worsening and increasing severity and increasing necrosis. In addition, hydration by improving perfusion to the other tissues which is affected. We all know pancreatitis is not a single organ which is affected, it's a multi-organ disease when it happens. By improving perfusion to other organs, it may be able to arrest the cascade of inflammation which is associated with the SIRS. So, to understand how we have reached where we are in the protocols of fluid resuscitation in pancreatitis, we need to actually look at how we have evolved there. That evolution has been sort of parallel with the evolution of fluid resuscitation in sepsis. And the first major idea that sort of cemented the way we do fluid resuscitation was from the Ranson's criteria of severity, where he noticed that more than 6 liters sequestration was an association with severity as well as mortality. And Tenner proposed that if you take the 6 liters of sequestration with the daily requirement of fluid in an average 70 kg individual, the required fluid resuscitation for the first few days will come to around 250 to 300 mils per hour. This was again sort of verified and reinforced by further studies. Whitcomb, for example, showed that in addition to the 6 liters, that in addition to the 300 mils per hour of fluid that is required, a initial bolus may be required. And this was again supported by a study by Pandor, which showed that actually giving a fluid bolus in the beginning and continuing that aggressive rate of infusion at around 300 mils per hour actually improved outcomes and actually prevented the worsening of pancreatitis into severe pancreatitis and having organ failures. Then another idea to evolve was the concept between early versus late resuscitation. Early is actually early, but late is not really late. Let me make that clear. Early is if the entire fluid deficit that has to be given is given, at least 1/3 of it is given in the first 24 hours, which is not in a goal-directed manner. The calculated fluid is given just like you give it in a burns. So not based on your hematocrit or based on your fluid responsiveness assessment or anything. He showed that that actually improves outcome. The late, what it means by late is not that it is late in terms of time, but you look at different goals. It could be your clinical goals like heart rate, urine output, hematocrit, and other laboratory parameters. And if there is, for instance, a hemoconcentration given more fluid, then that becomes late. But compared to late, early resuscitation was shown to be beneficial. And based on that, the first formal recommendation of fluid resuscitation in pancreatitis came in 2011, where they recommended that patients be resuscitated with 20 mils per kg in the initial phase, followed by 150 to 300 mils per kg for the next 24 hours. This sort of mirrored the surviving sepsis guidelines for resuscitation in sepsis as well. However, it was swiftly recognized that this is not ideal for all patients, and there were a lot of small studies, small trials, which showed that this may not always be ideal, and they compared what was called as aggressive resuscitation, which is what was recommended by the 2011 guidelines, the 20 cc bolus followed by 3 mils per kg per hour, to a less aggressive, or what they call a moderately aggressive resuscitation, which is 10 mils per kg bolus and half of that, roughly half of that. Most of the trials looked at 10 mils per kg as a bolus followed by 1.5 mils per kg per hour as an infusion. And many of them showed a benefit of aggressive resuscitation, but the benefits were mainly in the studies which had predominantly mild pancreatitis. In patients who had severe pancreatitis, for example, these two trials were done in patients who have only severe grades of acute pancreatitis, and in them, overall the evidence was not in favor of aggressive fluid resuscitation. In fact, it actually led to volume overload followed by all the consequences of volume overload, worse organ function, increased time on ventilator, increased ICU days, and even increased mortality. So in order to make sense of that, there were a lot of systematic analysis and meta-analysis, and almost all of them came to a conclusion that aggressive fluid resuscitation is not warranted, rather moderate fluid resuscitation is the way to go. And it is with this background that this large famous study, the waterfall trial, came. It was published in New England Journal of Medicine, one of the largest trials so far in acute pancreatitis, very well designed. It actually was intending to look at the development of severity of pancreatitis in association with fluid resuscitation. An aggressive arm, which was as per the previous guidelines, 20 mils per kg followed by 3 mils per kg as an infusion. The moderate group had a 10 mils of bolus given only if there was evidence of hypovolemia, not for all patients, followed by the 1.5 mils per kg per hour. Sadly, the study had to be cut short early because of safety concerns. The interim analysis showed that there was a lot of complications due to fluid overload, and it could not complete itself, and because of that, because it did not have the numbers that it had planned for in the beginning, it did not reach any statistical significance with regards to the primary outcome. But however, if you look at the control as well as the treatment arms, all across the board, the aggressive arm fared much worse compared to the moderate grades of fluid resuscitation. The primary aim, which was the development or worsening of pancreatitis into severe pancreatitis, actually was more in the aggressive fluid arms, as well as all the other parameters of improvement was better in the moderate fluid resuscitation, which sort of, even though it was not powered because of the numbers, because the signal was consistent and homogeneous, there was a lot of talk to actually recall the previous recommendation, but there was a small catch. The catch was in the exclusion criteria for the waterfall trial. The exclusion of cardiac failure, renal failure and all are acceptable. What was major concern is that the trial actually excluded patients who had moderate and severe grades of severity at the time of inclusion. So whether we can extrapolate this data and say that only moderate resuscitation should be done in all patients, or is it different for severe pancreatitis, those who present actually with severe pancreatitis? So to answer that, there were again systematic analysis and meta-analysis based actually on the severity of pancreatitis at presentation. Again, in terms of mortality, aggressive was not better than moderately aggressive. And in terms of worsening of organ function also, aggressive was not better than moderate aggressive fluid resuscitation. So based on this, in 2024, the American College of Gastroenterology came up with a guideline on management of acute pancreatitis. They shied away from naming a particular number as bolus and infusion, but they said all patients should receive moderately aggressive intravenous hydration, and if there is a chance of impaired fluid tolerance like a cardiac failure or renal failure, they should be monitored quite aggressively. And they stress that this is important only in the initial few hours, and the resuscitation had to be monitored quite frequently, especially the recommended monitoring with hematocrit as well as BUN. We will think that it will stop here, but then comes another study called the FLIP study. This was not a trial as such, but a well-conducted audit from United Kingdom, multi-center study rather, which looked at real practices across different ICUs in UK and Ireland, and the relationship between fluid resuscitation and outcome based on the severity of disease. They did not exclude any grades of pancreatitis. So as expected, the total amount of fluid received was different in between the mild pancreatitic grades and severe pancreatitis. Mostly the severe diseases would have more shock, and probably that's the reason why they got more fluids. They obviously got more fluids. But what is interesting is when you looked at the outcome, how they whether they survived or they died, there was overall, if you look at all patients together, there was no statistically significant difference between the two groups. You can see the nice violin and box plots looking almost the same. But if you tease out between the mild versus severe pancreatitis, it becomes interesting. Look at the plot now. So if they actually survived, in the mild group there was no difference, but in the severe group, those who survived got significantly more fluid compared to those who died. Quite significant difference, statistically significant, and much of this difference was in the amount of fluid that was delivered in the first 24 hours. Even the number of severe pancreatitis that developed is quite small. However, they concluded saying that in severe pancreatitis, increased volume of IV fluid resuscitation was associated with significant reductions in mortality. This odds ratio of 0.65 with good confidence interval not crossing 0, it cannot be actually neglected. So now where do we stand? Okay, quite clear that it is in mild pancreatitis. Aggressive is not recommended anymore. Moderate fluid resuscitation is significant. How about worsening of severity? Should we be aggressive? We don't have evidence to actually make a recommendation. However, in the 2024 recommendation, they give some eminence-based recommendation, which is sort of hidden away in the body of the recommendation. They say we only recommend moderate aggressive resuscitation. But remember, in mild pancreatitis, clinicians seldom appreciate that they have a important sequestration of fluid going on, and they fail to aggressively hydrate because they don't look as if they are fluid negative. Because if you look at their goals, or if you look at their fluid status, they are not negative. But if they develop hemoconcentration or a raise in BUN or an AKI, you have lost the window to actually prevent that worsening. And they argue that in these patients, you should actually aggressively hydrate and rather prevent the hemoconcentration and elevation in BUN. And sort of suggest that we could actually aggressively hydrate if fluid tolerance is not an issue in the beginning. Now we know that we have adequate tools for looking at both fluid tolerance as well as fluid responsiveness. We have had talks on Vex's protocol. So initially be brave and hydrate if there are no concerns about tolerance. It is important to acknowledge that it is not only the resuscitation phase that is important. You know that after that phase, there is a phase where you actually comes to a stabilization and evacuation. If required, you could actually use diuresis or fluid removal after the initial few hours, after which this volume is not much of a concern. So again, comes to individualization. Thank you.
Thank you, Doctor. We'll go to the next speaker. We'll have the question at the end of this session.
Hepatorenal syndrome, management made easy by Dr. Bikash Rajan Ray. We invite you, sir.
Good afternoon, everyone. Good afternoon, esteemed panelists. First of all, I would like to thank the JIGS organizer, Dr. Pradeep, for giving me the opportunity. Myself is Vikas. I am additional professor at All India Institute of Medical Science, New Delhi. And in next few minutes, we'll discuss the management of hepatorenal syndrome and how to make it easy. So it was never complicated. The management of hepatorenal syndrome is never complicated. It was made complicated because of some regional availability and not having clarity around the drugs to use. So in the last few years, it has been much more clear. So we'll go through how the therapy have evolved over the last few years and what is the current or simple way of managing the hepatorenal syndrome. So this is the place I work. So in next few minutes, we'll discuss what is the hepatorenal syndrome, the basis of pathophysiology on which the management is based, the types and the first line, second line management, and lastly about the organ donation or the definitive therapy that we have. So first question arises is what is a hepatorenal syndrome? So hepatorenal syndrome is the development of a renal failure, mostly in advanced liver disease or cirrhosis, sometimes in a pulmonary hepatitis also, who have a portal hypertension and ascites. Okay, so the pathogenesis evolved again all the inflammatory markers, cytokines, and ultimately leading to two things. There is splankling vasodilatation, which effectively decreases the volume, and that triggers the ADH secretion RAS pathways, ultimately leading to hepatorenal syndromes. Okay, so as you can see, the main pathology here, pathophysiology, is the sprankling, vasodilatation, and low effective volume. When they come to management, we target these things. First of all, we try to have a vasoconstriction, that is the sprankling vasoconstriction, and increase the effective volume. So on these two pathophysiology basis, all the management are best. Diagnosis is a diagnosis of exclusion, but many people think it's rather a systematic way approach to find out the diagnosis rather than to exclude other things. So previously it is classified as HRS1 or HRS2. Now the newer nomenclature is like HRS1 is HRS-AKI, that is HRS with acute kidney injury, and HRS with non-acute kidney injury, which again can be classified into acute kidney disease or chronic kidney disease. So it is the HRS1 which is around, it has been seen that it has been in a person who has a cirrhosis, portal hypertension, up to 30 to 40% of the patient at some time of develops HRS. On 32% of cases it is the HRS1 which is much more severe and have a poor prognosis. So the most of the management of the HRS that in a critical care setup is mostly involve the HRS1, and we'll discuss that. What is the HRS1? It's again systematic approach as the definition or the criteria says. You go one by one excluding other things to find out there is a kidney problem because of the these vasodilatations. So this is the stepwise manner you can find out whether it's HRS-AKI. So first of all, you have to diagnose AKI using the International Society for Ascites, which says that there is an increase in cardiac creatinine of 0.3 milligram per deciliter within the last 48 hours, or increase in more than 50% of the baseline in, or the urine output increases from less than 0.5 ml per kg in the 6 hours. So with this definition, and if there is a cirrhosis and ascites present, and you have to rule out any other causes of hypoperfusion like the shock from any other causes. You have to rule out any external causes that may causes acute tubular necrosis like the antibiotics, NSAIDs, diuretics and other nephrotoxic drugs, and any intrinsic parenchymal disease to rule out by finding out the proteinuria, hematuria, urinary cast, or any normal renal ultrasound. And if they are not ruled out and you try to do the basic initial management, that is the vasoconstriction and volume expansion, even after 48 hours that is not there, so you have a diagnosis of HRS-AKI. Coming to the management, which is our focus here. So factors that affect the management of the therapy in case of HRS is basically three things. One is admission or the location of the patient, whether the patient is in ICU or in case of ward or any other location. Availability of the certain drugs, because the most important drugs that are available, this has created some confusion in last few years. Mainly the telepressin, which is now the standard care of or fast-line drug treatment, was not available in the US and not approved by the FDA till 2022. So that created a lot of confusion. So different guidelines or different societies recommend different pathways, but now it is much more clear, and we'll discuss like that, and whether the patient is a candidate for the liver transplant or not. So these are the factors that will determine ultimately the treatment you have got. So initial management, as I told you, is always vasoconstriction and volume expansion. So if you try that and if it is not there within 48 hours, it's not responding, so that is you are in the hepatorenal syndrome. If response, you can exclude the HRS and treat the individual component. Then you try the first line management mostly, and if it is failed, you go for second line management, and if then that's failed, it is the only two options have left. Either you go for a definite treatment, which is the liver transplant, or you can go for a palliative care along with the second line treatments. So with that, as I told you, the initial management is always you stop all the diuretics or nephrotoxic or antihypertensive drugs that patient is on, stop the beta blockers and expand the volume for 48 hours, mostly with albumin. The dose is around 1 gram per kg, up to in 48 hours you go maximum up to 100 gram, these things. So if with that is not responding, now you come to the primary approach for HRS. So the historically, it's not exactly historically, maybe in last few decades, so all the guidelines or all the society says that whether you have a availability of telepressin or not. If telepressin is available, you go for telepressin and albumin, and if it is not available, then you decide whether the patient is in the ward or in the ICU. In a setup of ICU, you can go for noradrenaline along with albumin, and if it is outside ICU or these drugs are not available, you can go for midodrine, octreotide or albumin combination. So these are the classic approach. However, the telepressin is the newer drug and which is a selective V1 receptor, acts in the vascular smooth muscle specifically. It's although acts in the both systemic circulation, but it has a better effect on the spanking circulation. Also, it dilates intrahepatic vessels, all leading to reduction in portal pressure and effective decrease in the HRS. So it has been, before also 2021, there are a lot of studies and a lot of meta-analysis in which they have, the telepressin has established its role as a better drug for the treatment of HRS. As you can see, this is in 2017 meta-analysis between telepressin and placebo. Definitely telepressin is better. Similarly, between telepressin and norepinephrine, they don't find any difference. Again, another meta-analysis in 2018, you can find out that telepressin versus placebo, telepressin is better, and telepressin and norepinephrine, again the same finding, they don't find any difference in mainly for the reversal of the HRS. So also the Cochrane review say there is a very low certainty that this telepressin is better than the conventional treatment of octreotide, albumin, or the use of midodrine. So, but the best paper or the game-changing paper come in 2021, that is the CONFIRM trial. So this is a trial in US and Canada involving around 60 centers, 300 patients. They use this study protocol. There is an intervention and they follow it for 4 days and they follow up the patient in 30 days, 60 days and 90 days. So this is the trial where the cirrhosis patient, 300 patients are included. It's a comparison of the telepressin plus albumin versus placebo. However, it's not the placebo. Albumin is the standard treatment, both the groups. What they found that there is significance, HRS reversal is 32% with telepressin and albumin compared to the 70% only placebo or the albumin group, which is very significant. However, despite all these things, the FDA approval not given, so there are some controversy. However, with repeated applications in 2002, the FDA gave approval for as a first-line treatment of telepressin, but they have certain rules, certain conditions, because in this study you can find out the respiratory failure is significantly higher in the telepressin and albumin group compared to that of the group where a placebo or albumin is used. So that is the main concern. So they approved telepressin with some cautions that whenever you are using telepressin, you should always monitor for hypoxia. You monitor for any ongoing ischemia from the periphery or splanchnic circulation. You should monitor, there should not be any fluid overload, because that again increases the chances of hypoxia. So these are the conditions which they approved. Now it is also, even if with the approval, it has not gained that much popularity mainly in the Western population. Okay, so as I told you, they say you avoid if there is a hypoxia, ischemia, or there is a ACLF or progression of ACLF. And although if you use that also, you also monitor for these parameters. Whether these parameters are present, you should stop these things. So the telepressin, if you compare with that of the noradrenaline in HRS, as you discussed in the previous meta-analysis also, they don't find out any difference. However, in this meta-analysis also, they find out that the reversal between of HRS between both the two drugs are equal. The 30 days mortality is not difference. However, the adverse effect are significantly less with noradrenaline. So that puts forward the case of noradrenaline because it is much more cheaper than the telepressin and it has lesser adverse profile. However, the advantage of telepressin is that it can be given as a bolus. You don't require any monitoring. For the noradrenaline, you require the blood pressure monitoring and ship the patient to a intensive care unit and have a central line for that. So it depends upon which patients or what are the logistic you have to apply these things. Regarding telepressin versus midodrine plus octreotide, it is found that telepressin is far better. Midodrine and octreotide, although classically has been used, their effectiveness is very less. Again, noradrenaline versus midodrine, again noradrenaline is found to be better than these combinations. So if you say these are the first line drugs are like telepressin and noradrenaline with albumin, so if you are not responding to that, then the next thing is you go for second line or non-pharmacological management. Most of the time there are few options you have. One is the tips. You can go for the tips, but there is only one meta-analysis in which they have around 128 patients. They found that tips decreases HRS in 93% of the patients. However, this study in this meta-analysis are very poorly conducted. They don't have a comparative group. The heterogeneity is very high. It is very hard to implement this data. Also, the complication rates of tips are very high. with tips, there is increased rate of hepatic encephalopathy, increasing worsening of the LFT, bleeding complications, and if you are using a contrast, that may again aggravate the kidney injury. So with all these factors, it should always be managed, although it's an option, it should be used in selected patients rather than a standard second-line drugs. The second option is RRT, that is renal replacement therapy, and it has been found that in multiple studies, it does not affect the mortality. So the current consensus is that you use RRT only if the patient is waiting for a liver transplant as a bridging therapy. Also, with increasing in number of days of RRT, the chances of reversal of HRS even after liver transplant decreases. So these are the concerns. That is why only potential liver transplant candidates as a bridging therapy, or in a potential reversal condition you consider RRT. And if the patient is not suitable for a transplant, it is better to first explain the palliative care along with before going for the RRT in this group of patients. Lastly, artificial liver support system, it is not, there is hardly any report of use this in HRS. Normally also there is conflicting report whether it is useful or not. So that is the thing. Other experimental treatment like misoprostol and NAC, angiotensin converting inhibitors, and peritoneal venous shunt has been used on experimental basis. Neither has been to be found out to have a consistent result or any significant improvement of HRS. To come to the simplified approach, if you say with all the first line and second line TPRS, so the current approach that is mostly practiced, that is used by the confirmed trial. So if you have all the criteria that is met for the HRS, then you assess whether the person is a candidate for telepressin therapy or not. So you rule out any ACLF grade 3 or more, you rule out any hypoxia, you rule out any ongoing ischemia, and lower seroconversion if differ. And if these are present, you start with telepressin. The telepressin dose you start is around 1 milligram, although this is 0.85, because in the US it is the telepressin is written as telepressin rather than the salt form, which is telepressin acetate. So 1 gram of telepressin acetate is telepressin of 0.85. So that is the 1 milligram you use IV telepressin every 6 hourly, along with albumin around 25 to 50 grams per day. And your regular throughout, it is for 48 hours. So it is for 3 days. So you monitor all the things that will telepressin with the 3 days. You evaluate the patient on the 4th day. If it is the creatinine, the serum creatinine has increased more than 30%. So you are happy. So now you continue the therapy HRS till there is HRS is resolved, or for maximum of 14 days. If it is less than, the creatinine decreases less than 30%, so you can increase double the dose, and you can continue again. And if it is not affecting, then you stop telepressin, and then they says because noradrenaline is equally effective, you can have at least a try of noradrenaline this thing. So you start noradrenaline around 0.5 milligram per hour. The aim is to increase around the mean arterial pressure around 10 to 15 milligram only. Continue therapy until HS reversal or 4 days. So no reversal after 4 days, you have a decision whether to go for a secondary therapy or an indefinite therapy. So patient in ICU, if the patient is ICU, it is because it is, many people strongly argue that because it is equally effective, you should go for telepressin. If you go for norepinephrine with albumin rather than telepressin, again the target is to increase it to 10 to 15, mean arterial pressure 10 to 15. The predictor of telepressin responsives are low creatinine serum, low MAP, severity of liver disease, presence of alcoholic or SRAS, and urinary NGAL level less than 200 nanogram per liter. I will take 1 more minute. So lastly, the organ of transplant is there. Liver transplant is the definite treatment. There has been multiple studies. They have been found that after liver transplant, HRS removed around 75% cases within 2 weeks. So definitely that is then there. But predictor of non-recovery of after liver transplant are duration of pre-transplant dialysis. With each day, there is a decrease of chance of reversal by 60%. Older age, higher baseline, seroconversion, prolonged ischemia, exposure to non-ferroxide diabetes, and others are the indicator of slow recovery. So even after the transplant, it has been found that 6 to 10% of the patient have a failure or kidney failure after 1 hour, after 1 year after transplant. So there's a concept that you can, in certain patients, you can go for simultaneously liver and kidney transplant, and in different regions, different guidelines are there. So what is the cutoff? It is not clear. In many centers, it is for 6 weeks. It is for more than 6 weeks, the dialysis dependent, they go for simultaneously. In many, it's 12 or in 18 weeks also. So we have yet to have a clear-cut guideline for that. Lastly, the take-home is that the HRS is a rare but serious complications of AKI with cirrhosis. Is timely diagnosis and early intervention with telepressin albumin can improve that. When you are using a telepressin, you always have the causes, what are the side effects that can have, and what are the mandatory monitoring you have. Noradrenaline is equally effective, and you can use it as a cheaper options, and in where ICU monitoring is there. Any questions?
Thank you, Dr. Vikas.
Next one will be a pro-con debate. The topic will be selective digestive decontamination in the Indian setting.
I'd request Dr. Asif to join us on the dais. I think it was held up in the previous, yeah. Sorry, go on.
So selective digestive decontamination in the Indian setting. SDDs have been coming and going. I think this is a good debate. The pro debate will be by Dr. Mona Lisa Sahu. I request Dr. Mona Lisa to come and start the presentation, please.
Good afternoon, everyone. I'm thankful to the JIGS committee for giving me an opportunity. The topic of debate for today is the selective digestive decontamination in the Indian setting. I am standing for pro, and today's debate is against the doyen and legendary figure in critical care disease, critical care infection. And I think I will not disappoint you all in the debate. So selective digestive decontamination is basically the application of the topical non-absorbable antibiotics in the oropharynx and the digestive tract, which typically include tobramycin, colistin, and an nystatin combination given as an oral paste or a gastric suspension, with or without the combined use of a systemic antibiotic for a period of 5 days, which may be a third generation cephalosporin or an alternative, without an anaerobic spectrum. So what is the logic behind the use of this STD? It is we mainly target to prevent the secondary colonization of the potentially pathogenic gram-negative bacteria along with the Staph aureus and the yeasts through the application of the non-absorbable antimicrobial agents in the oropharynx and the GI tract, along with preemptive treatment of the possible infections with the commensal respiratory tract bacteria through the systemic administration of the cephalosporins for the first 4 days in the ICU, and maintenance of the anaerobic intestinal flora through the selective use of antibiotics without an anti-anaerobic activity. So if these three things are combined together, this basically can help in preventing the ICU infections in the critically ill patients. And it has also been adopted in a few countries without a proven track record of adverse outcomes. But there has been a concern about this intervention causing a theoretical increase in the antimicrobial resistance. So let us go through the evidence that is there in favor of it. So there are a large number of RCTs that have proven that SDDs, most of them have been conducted in the Netherlands, Australia, and the New Zealand, and other countries as well. And they have adopted this mechanism of SDD to prevent the infections. But there is some reluctance in the intensivists of the other countries to adopt this. The first study was published as old as 40 years back, and this was done in the neutropenic mice model. And the other human study that was published in the intensive care medicine back then in 1984, which showed there was an improvement in the multiple trauma patients they included, 122 multiple trauma patients staying in the ICU for a period of more than 5 days, needing mechanical ventilation. The infection rates were about 81% in them prior to the intervention. And after the intervention, there was a decrease in the potentially pathogenic microorganisms, leading to a decrease in the endogenous source of infection, and the total infection rates decreased to about 16% from a high number of 81%. This was back then in 1984. Then came one of the major landmark studies, which was done in the Netherlands, which was published in the NEJM in 2009, and the post hoc analysis was published in the Lancet Infectious Diseases in 2011. It was an open-label cluster group randomized crossover study, which included 13 ICUs in the Netherlands, and the period of the study was from 2004 to 2006 July. And the study sample size was pretty large, 5,927 patients were randomized to receive the standard SDD or not. And the outcomes were pretty significant. The acquired bacteremia after 3 days was significantly low, about only 124 cases in the SDD group, whereas it was as high as 239, that was 13% in the standard care group. And the acquired bacteremia with the highly resistant organisms, that was also lower, only 8 cases in the SDD group, whereas 20 in the standard care group. The incidence of the resistance bacteria, including the Staph aureus, the Strep pneumoniae, the GNBs, as well as the Candida species, they were also lower in the SDD group as compared to the standard care group. The consumption of the antibiotics, the carbapenems, and all the systemic antibiotics was also lower, about 45% in the cases of the SDD group as compared to the standard care group. Another landmark study, that was the Sudoku trial that was conducted over a long period in the Australia, with the Sudoku group from the Australia and the New Zealand, and the study is still ongoing in the Canada. This was published in the JAMA in 2022, and it was also a clustered crossover randomized control trial, and the sample size was about 5,900 patients in 19 Australian ICUs, and the study was between May 2017 to August 2021, and it's still ongoing in certain countries of Canada. The ICUs were randomized over whether to adopt the SDD or not over 2 alternating periods of 12 months, separated by a 3 months gap. In the SDD group, they received 6-hourly application of the oral paste of the suspension, and along with the IV antibiotic for 4 days. The control group consisted of 3,191 patients. This is the visual abstract of the study. We showed that the SDD, although did not decrease significantly the mortality rate, but it includes clinically important benefits which are enumerated. The secondary endpoints were significant, like the number of days post ICU without the infections was longer, and also the ecological outcomes, like the number of newer infections with the GNBs, the newer positive blood cultures, as well as the newer cases of Clostridium difficile infection. They were all less in the SDD group as compared to the standard care group. This was a post hoc analysis of that Sudoku trial. We showed which dichotomized the patients with the acute brain injury. The patients with acute traumatic brain injury, or the SO, were included, and the primary endpoint was the mortality at 90 days mortality, and it was seen that it was significant reduction in the acute trauma brain group. And the reduction was about 5.7%, which was significant in the SDD group, and with the odds of 7.76. All the outcomes, the primary as well as the secondary outcomes, were met. As you can see, all of them favor the ICU death at the 90 days, and the death in the ICU days alive, free mechanical ventilation, free of ICU admission, all of them favor the SDD group in this study. So the better outcome in these neurologically impaired patients is mostly due to the prevention of the secondary neurological damage that can be caused by the infections. As we know that these neurological patients have an increased risk of aspiration, require prolonged mechanical ventilation. There is a component of neuroimmune suppression, as well as the pathogen translocation which can occur in these patients. So using the SDD is a very approach which can be promising in this these group of patients. Another important study, the SELECT trial, was conducted in the patient group of the colorectal surgery patients, which was published in 2019, and showed that there was a decrease in the number of anastomotic leakages as well as secondary complications in these group of patients. As you can see, the number of surgical site infections, the pneumonia, as well as the urinary tract infections were lower in the group which received the SDD as compared to the standard care group. Another trial was also conducted in the pediatric population in the UK, where they also showed that similar outcomes. Larger trials can be conducted in this group, and it was done in the September 2021. So there is several meta-analyses have also been published on this, and the meta-analysis shows that this was one of the important meta-analyses which included 29 studies, and it favored that there was a mortality benefit with a significant odds ratio. And one of the major meta-analysis which was published in 2022 in JAMA, which included 32 RCTs, we showed that there was a decrease in the mortality rates. As you can see, 29 of the studies fall to the left of favoring the SDD. All the outcomes were better. It was associated with the decreased risk of the VAP as well as ICU-acquired bacteremias. And also the effect of SDD on antimicrobial resistance was also lower. In the Indian context, we are skeptical that the use of STD might increase the rate of infections, but there are no certain RCTs to prove that. But conducting an RCT is also not very much possible for every aspect. So there is also several studies which show that there is a decrease in the digestive decontamination leading to like there are no increase in the cases of antimicrobial resistance, and these have been shown in several studies conducted in the tertiary care hospitals. This is one which was conducted in the Spain where the resistance rates are higher, and they showed that there was no clinical increase in the emergence or spread of resistance after the use of HDD. There are like other studies which have shown similar findings, like a 21-year-long study which showed that there was no increase in the ICU contamination, ICU resistance rates, or increase in the consumption of antibiotics. Another study which also showed similar findings. Significant reduction in VAP and secondary bloodstream infections were also there, and there was a decrease in the antibiotic consumption in these studies. So these are the significant findings which we can reciprocate in our country, although there are no several RCTs for that. This is another study which shows a similar, which is a 16-year-long study showing that there was no increase, no overall increase in the systemic antibiotic use. And the points in my favor include there are severally proven benefits of the SDD, fewer antibiotic resistant organisms and fewer positive blood cultures post SDD. It is non-inferior as compared to the Clostridium difficile infections. The lower incidence of VAP and ICU acquired bacteremias, slightly shorter duration of VAP in the patients with SDD, as well as no increase in the antibiotic resistance. Just a minute more. So it is just cannot go alone, but there should be several aspects which should be there with the SDD, like stringent infection control practices, antimicrobial stewardship program should be in place. The antimicrobial resistance surveillance should be ongoing to see if there is any increase in the resistance. Standardized formulation of the SDD, protocolized administration, and healthcare worker education. All these things need to go in hand for a successful program of SDD. So the SDD has minimal adverse outcomes and has been proven to decrease the mortality, decrease the rates of nosocomial infections, and also the duration of organ support without evident side effects. So the current body of evidence cannot be just ignored, and we should be going ahead, having more studies, and it has been well accepted in the Netherlands and other countries as well, and we can put it in our patient, especially in the patients with the acute trauma group, as well as the colorectal surgery, where the benefits have been proven. So I think at the end of my debate, I have been done my best. So I hand it over.
Thank you, Mona Lisa. Now I invite for the cone and Dr. Yatin Mehta. No need to introduction. Sir is the past president of IACCM and sir is the director of Department of Anesthesia and Critical Care Medicine, Medicity, Medanta, Gurgaon. Sir.
Thank you, Ranveer. Pleasure to be here again. And nice to see so many people in the hall post-lunch. Now, if you had a simple question, if you had to choose between this and this, what would you choose? If it is an art gallery or it's a museum, you will choose Mona Lisa. But it's a scientific meeting, I'll show you why you should choose what I'm saying. I bring you greetings from so-called best hospital in the country, so you should listen to me seriously. What is the concept of selective digestive decontamination? No? No, one slide is not coming. Okay, for your information, it is a 50-year-old concept. The first experiments were carried on in irradiated chimeric mice transplanted with leukemic cells. And we are trying to extrapolate it to human intensive care units. And there is no standardized STD. Either you give it in the oral cavity, or you give it with IV antibiotics, or you give it both oral and IV. So it's not a standardized therapy. So what papers have been shown has been a mixed regime. Is it a misnomer? Yes, actually STD is no more really used. Use control of gut overgrowth, or COGO. And in my opinion, it's a no-go. Because the mechanism is not certain. How is it going to work? Does it reduce the absorption of endotoxins? Does it cut down the gut bacteria? Does it change the bacterial profile of the guts? Should we be giving IV, or should we be giving along with parenteral, or should we be giving both? Don't know. First RCT was published in 87 And there was 60 RCTs, about 15,000 patients, period of 25 years. Tell me something which has been discovered 50 years back, why is it still not used extensively? Not even in Europe, they don't use it. And as I said, there's no single regime of protocol. Many questions still remain. What is the optimal dose? What is the optimal content? What are the antibiotics which you should be using? Which population you should be using it? How long do you give it for? And so on and so forth. This was a meta-analysis, 1998. This review does not allow a unique regime to be recommended. That's the conclusion. The use of topical antibiotics alone, however, is not justified by available data. Second comment, finally, it is important to bear in mind that given the lack of valid data, no absolute conclusions can be drawn from this systematic review on the risk of antibiotic resistance, which is a huge problem in India. And we, in fact, assume that the different drug combinations categorized as either topical plus systemic or topical only were equivalent. Most of the studies which have shown benefit are ones in which IV antibiotics also have been administered along with STD. Again, another meta-analysis, 2021. Many years later, conclusion. This was a study of 11,000 patients, 41 RCTs. We cannot rule out that the systemic component of the combined treatment provides a relevant contribution in the observed reduction in mortality. No conclusion can be drawn about adverse events as they were poorly reported with sparse data. So these were the conclusion in 2021. This was a trial which my esteemed colleague discussed, Sudoku trial. That is what is quoted very, very often. The benefit which was shown in traumatic brain injury, by the way, was an afterthought. Post hoc analysis really don't mean much in planned randomized control trials. So this was the largest and most recent randomized control trial, 6,000 adults, conducted in an environment of low endemic antibiotic resistance, Australia and New Zealand, which is the lowest incidence. I used to work in Denmark a long time back. We used to roam around all over the hospital in the same civilian clothes. The only prophylaxis which was given to surgical cases was penicillin, a single shot, and the infection rate was lowest. Netherlands has one of the lowest infection rates in the country, and so has Australia and in the world, and so has Australia and New Zealand. So this is not really extrapolatable to India. And they could not demonstrate any significant difference between the incidence of VAP, ICU-acquired pneumonia, bacteremia, or new C. difficile incidence. However, the confidence interval does not exclude a clinically important benefit. Okay, let's agree for a moment, but what are the weaknesses? It was a single country with limited validity, especially very low antimicrobial resistance or infection rate. There were 1,203 protocol violations in the study. Almost 50% of the patients received IV antibiotics in addition to STD. So that uncertainty persists as to what STD regime is best. Low rates of antimicrobial resistance found in all cultures and short period of ecological data collection may limit the power to determine STD's non-inferiority. Subgroup looking at use of IV or no IV antibiotics in the simultaneously published meta-analysis seems to show a benefit only with IV antibiotic usage. And power to detect a 4.2% reduction in mortality, this has been very optimistic. So what are the risks involved? She mentioned kindly about the antimicrobial resistance, and we know what is the incidence in India. We all are suffering with it. So let's look at it. Halaby showed an increased prevalence of colistin-resistant microorganisms, which probably was due to failure of hygienic measures in the ICU. Osjic reported a trend to an increased incidence of aminoglycoside resistance. Now, colistin is the last bazooka which you have to hit your patients with. And that also, if you're trying to develop resistance to that, you can imagine what situation we'll be left in. Although there were some weaknesses in these studies also, single center design, extrapolation of the ICU is difficult to make, and so on and so forth. Second, third generation cephalosporins, tobramycin, gentamicin, poly-B colistin, and ciprofloxacin in aerobic gram-negative infections, other antimicrobial gram-positive microorganisms were not studied. So MRSA was not studied in this. As we know, India has one of the highest incidences, including NDM. We are the inventors of NDM. So STD is unlikely to be of any benefit here, but other harm is possible. One of the highest rates of resistance to antimicrobial agents because antimicrobials are used in humans as well as in animals, poultry farming. So rebound infection, once the patient is discharged from the ICU and the antibiotics, whatever is. So this was a study which studied patients who received STD and did they get a secondary infection. So hospital infections are up to 50% or more common among patients discharged after receiving either STD or selective oral decontamination, 50% more during ICU stay versus patient discharge the following standard of care. The optimal time for washout after STD or SOD withdrawal to avoid rebound carrying over into subsequent CRT control period is unclear. So how long this effect is going to last is difficult to say. Once the patient is discharged from the ICU, doesn't necessarily mean he's going home. He's going to go to the hospital environment. If he goes home, you don't know what sort of environment he's going into. So STD is a selective digestive decompensation, not sure. There's an article, I'll just take a minute. Since the landmark study by Stutenbeek and Zantra demonstrating the beneficial effects, 40 years ago, 1,000 peer-reviewed articles have been published. However, the clinical value of STD remains contested, with nearly half of all publications being editorials, letters, and brief communications. Most of the studies in 7 RCTs conducted in ICUs in which MRSA was endemic, there was a trend towards higher MRSA infection in patients receiving STD. So MRSA is happening in India. We are well aware. So I thank you for your attention, and I think the case is quite clear. Thank you very much.
Thank you very much, sir. And question answer we will discuss later on.
So our next topic is all aspect of total parental nutrition prescription for novice. And the speaker is Dr. Sanjit Sridharan, and he is Director Critical Care, SLN Raja Hospital, Fortis Associated, Mumbai.
First of all, I was feeling very awkward, Chairperson's perspective, with this kind of a topic which says for novices, and I'm speaking in front of such an august audience. It's something that's a little bit awkward for me. But I must tell you that's really, there is no real competency-based training that has ever been done in our country for total parental nutrition. So I don't think this is the wrong way to actually address this particular topic. In fact, we say we learn on the job, but it's important to understand that the only time we are using TPN in the entire time is 1%. 1% of our time is spent on TPN. So that's why we don't even learn on the job, if you ask me. This is not something that we do on a regular basis. That's why it's got very limited usage, which actually does not give us the experience to in this matter. So what I'm going to do is I'm going to tell you about the basics of TPN. I mean, if I were to touch the basics on TPN, there's so many formulas that are there, so many formulas that at the end of the day we get tired just looking at formulas. That's the amount of formulas that we have when you look at TPN. But what I'm going to do is I'm going to divide them into understanding how to prescribe TPN safely and optimally. And the answer to that is to prevent a complication. So you do TPN to prevent a complication in intensive care unit, because the magic of nutrition never occurs in the first 7 to 10 days. All the nutrition effect which happens after 3 months. So in the first 10 days when we are actually going to give total parental nutrition, it's important to keep it optimally safe. That's very, very important. And the first thing when you talk of safety, when you talk of TPN, is actually infections. Everyone thinks that the moment you start TPN, the first thing that you get is infections. And look at this review. This is a review of 18 RCTs. 18 RCTs was done, and 11 RCTs of them had infectious complications that actually looked at TPN versus enteral nutrition. And if you look at it, PN, it showed, had more infections as compared to enteral nutrition. It's very important for you to understand. However, if you read between the lines, 10 out of them were more than 15-year-old RCTs. And 1 out of 11 was only 10 years ago. So we can't look at this data. What we were doing 15 years ago is not what we're doing now. I mean, we can look at this data and say that PN has more infections as compared to EN. In fact, another systematic review that came in 2021 also said the same thing. It said that PN has got a little bit more infections as compared to enteral nutrition. Here again, there was 1 out of the 7 trials were less than 5 years. The rest, all of the trials were close to 10 years old. Yes, it has got an infectious pathology. It does cause infections. CRBSI is known to occur with a whole lot of things. It has occurred with duration of catheterization, times of tube drilling. So many things are there which actually causes catheter-related bloodstream infections, of which one of them is actually total parenteral nutrition. So there is one thing that actually causes, among the rest of the entire things that happens with when you look at CRBSI. So if you will not get any problems with infections if you take strict aseptic precautions, if you keep trophic feedings on if it is possible, and if you reduce the duration of central TPN and PN. This is what we do regularly, isn't it? So infections are not a problem. It is the way you treat these patients is more of a problem over here. So for the novices, it's very important to understand that you have to do these 3 things very, very well. Now let's look at how to treat, get away from metabolic problems. And if I were to finish this entire talk in just one slide, this is the answer. The prescription, the dose of prescription, the rate of prescription, the duration of prescription, and the maximum volume that you have to give. This is what will completely solve the entire problem of metabolic problems. And this slide is so important for us that it says that the rate of 0.25 grams for glucose or an amino acid rate of 0.1 gram per kilogram per hour is very, very important over here, especially because of the fact that if you were to give more than that, there's going to be nausea, vomiting, there's going to be emesis. Apart from that, there's going to be renal loss of amino acids. This is what is going to happen with these amino acids. Importantly, if you go more than 3.8 grams per kilogram of amino acid, there is going to be an excess amount of ammonia creation. That's why the dose is around 2 to 2.5 grams per kilogram. When it comes to fats, it's important not to go fast because it causes fat overload syndrome. This is another problem that will occur. The patient will be worsening with respect to anemia, thrombocytopenia, heart failure, and things like that, but it's all going to be fat overload syndrome. So that's the dose that you need to give for fats. And for all practical purposes, if you give glucose at a very high rate, the glucose utilization rate is going to be low, and at the same time, hyperglycemia will set in these patients. So if you take these 3 points and then put up your prescription for total parenteral nutrition, probably you'll be very, very safe. And there's so much of TPN that we have, different kinds of TPN that are available in the market. Now let's just think, let's just simplify one of these prescriptions for us. All right. So when you're actually writing up a prescription, you need to understand first the prescription of the macronutrients, you need to understand the maximum tolerable fluid, and you need to understand the specifications of the bag that you're going to use, and then monitor the complications, and this makes it simple. If you thought this is simple, no, it's not. Let's take the example of Jennifer. Jennifer is a 50-kilo individual who basically needs TPN, and I've decided the prescription to have 2,300 kilocalories and 85 grams of protein, and there is no restriction of volume. So we now know the prescription, we know what is the maximum tolerable fluid, we now need to understand the specifications of the bag. So for the purpose of this talk, I've just taken one of the prescription inserts from one of these bags that we have. And we see there are 4 kinds of bags, 2,000, 2,500, 1,500, and 1,000. If I were to take this prescription, the bag that actually gets to the closest of this is this bag, isn't it? 2,585 grams of protein. But the prescription, if it changes to 1,000 kilocalories and 70 grams, I don't think there is a single bag that can actually do justice to this over here. In fact, the last bag that we have of 1,000 kilocalories will give you only 34 grams of protein. So it's impossible actually to give this kind of protein in the event with that particular rate. And most of our patients are actually in that prescription type. They are not of the earlier prescription type. So let's see abroad what happens. Abroad, there are all of these kind of varied prescriptions. In fact, they have exacta compounders where you can actually use different kinds and compound them together in a way that is very, very safe. This is what happens abroad. But unfortunately, we don't have these kind of things in our country. We don't have it. And that's where we are left with things like how to mix, manage, and try to keep it safe. So let's look at this prescription and we'll try to solve this prescription. 1,200 calories, 70 grams, and 1,400 ml. So let's look at this. So the first bag is the one that I'm going to use, where is 900 kilocalories over here. I have 34 grams of protein, isn't it? So my deficit comes to 36 grams. Now look at amino N. If I were to add an amino acid, 500 ml, it's 50 grams of protein, and I need to add another 36 grams, means I need to give 360 ml more. Okay, I'm going to give 360 ml more. Total required 360 ml is extra. So the rate is, the max rate you can give is 5 grams per hour. So the final prescription comes as 42 ml per hour for 24 hours. That's 1.3 grams per hour of protein, and amino acid at 36 ml per hour, 3.6 grams per hour for 10 hours. So this is a very simple prescription. Let me tell you, it's a very, very simple prescription. This is not the usual prescription in the intensive care unit. In the intensive care unit, things become rather complex. It's rather complex. It's not easy at all. Let me give you a sample prescription that's happening in the intensive care unit. 2,100 kilocalories of energy, 105 grams of protein per day, and a fluid of 2,400 ml is what we thought. So the first thing we do is calculate the protein. So the protein over here would be 500 ml of 10% amino acid, which let's call it AA10, and that will give me somewhere around, and 500 ml of 50% dextrose, which is, let's call it D over there. So when I combine these two together, what I'm going to get is 250 grams of carbohydrates and 50 grams of protein in 1 liter. This is what I'm going to get. My requirements are somewhere around 105 grams, remember this, okay. Now for a 105 gram of protein, I will require at least 2,100 ml of this particular solution, isn't it? I will require 2,100 ml of this particular solution, but that solution will contain now 525 grams of dextrose. Now that makes it a very high amount, because the max dose you can give is 7 gram per kilogram per day, means 490 grams. Now this is a problem. So what do I do in this case? What do? I can probably just double the amount of amino acid there, make it 20%. That will give me 100 grams of protein. And then my entire amount that I'm now looking at will be 100 grams of protein or 250 grams of carbohydrate. And this solution will now contain 262.5 grams of dextrose. A simple calculation, isn't it? A simple calculation like this. And then you look at the remaining energy that is required. What is the remaining energy? 262 grams of dextrose means 892 kilocalories. Now you subtract this from your total calories that you have, and what you will get is 1,208 calories. How do you fill in for this? Lipids. Simple. You look at lipids over here, put lipids over here and calculate the lipid requirements here. And here is the lipid requirements. It's 600 ml of 20% intralipid. That's the answer. So the entire TPN prescription would actually depend, if you were to divide this to 24 hours, will look like this. Dextrose amino solution of 87.5 ml per hour. Where the rate here is less than 0.25 grams per kilogram, and amino acid is less than 0.1 grams per kilogram per hour. This is the actual prescription with an addition of intralipid at 25 ml per hour. This makes it safe, this makes it metabolically right, this makes it as simple as possible if by any chance, and yes, you have to add MVA and trace elements to these bags separately. At the end of the day, to make it more safer, there are a few things that we all know, and that's glucose control, checking the electrolytes, keeping them in place. You need to do the electrolytes twice in the day, and if you're on home TPN, at least once in the week. If you have to look at the line sites on a daily basis. This is something that needs to be done every 8 hours. Every 8 hours, there has to be the line site to be checked. It's very, very important to look at this. We do it anyways for all our CRBSI patients. You have to look for pain in the abdomen, because things like acute cholecystitis, like aseptic cholecystitis, all these things can come in over here. The fluid balance is very, very important. The CBC, LFT, and coagulation needs to be looked at for a long term. And remember, one of the biggest problems that you get in these cases is refeeding syndrome, because these are those patients that were at risk for malnutrition for which you've actually started TPN. And this is very, very important for us to understand and keep a watch on refeeding syndrome. But at the end of the day, I feel TPN is much more safer than assumed. It's much more safer provided you know how to do this. The second thing is, it's very, very easy to prescribe provided you take the attempt to sit and calculate. It's very important to sit and calculate and not just send 80 ml per hour and go home. That's not the way it's supposed to be done. It needs to be, you have to sit and prescribe it and calculate it very well. Complex cases would require personalization. There is no doubt about it. Complex cases would require personalization, and knowledge of the complication is definitely a must. Thank you very much for the patient hearing.
Thank you.